This is the video of laparoscopic cholecystectomy in acute cholecystitis, that is a grade 1 mild form of acute cholecystitis. So, after making camera trocar at the level of inferior surface border of the liver, I am making a my right hand working trocar at the level epigastrium, and I do not put 10 mm initially, I put 5 mm trocar because the 5 mm instrument in 10 mm trocar has a less stability. So, after the callet dissection is completed, that is a very critical thing in lap chole. Once the callet dissection is completed, then I make it 10 mm for a clip. So, now you can see the acute edematous cholecystitis. I am making a 5 mm trocar, that is my left hand at the subcostal level at the fundus of gallbladder. This is the lateral trocar for retraction of the gallbladder. Now you can appreciate all the 3 trocar is focusing towards the gallbladder to minimize the postoperative pain in the port site. I am just checking the gallbladder. You can see this is the acute. 3 videos I showed a regular gallbladder. The same regular, the small size gallbladder, the cystic duct obstruction, then it's become a edematous, large, distended, and it's become a thick walled gallbladder. Since it is acute, this patient is must be around 48 hours to 72 hours of acute cholecystitis. And same way, even though gallbladder is edematous and thick walled, our aim is to make an anterior peritoneal incision on the callets and posterior peritoneal incision. So, we do not change any steps, and you can see here I am making a peritoneal incision, and you will expect a thickened peritoneum and then edematous tissue and thickened gallbladder wall. Now, this is the lymph node. It is a very large lymph node on the cystic artery. I am not able to hold the infundibulum. In last 3 videos, you can I will show how to hold the infundibulum, how to retract medial and lateral traction, but this case I am not able to hold it even with the wide uh, instrument, large instrument. So, this is the difficulties we are facing in acute cholecystitis. The peritoneal covering of the callets is thickened and then thickened and edematous gallbladder wall. So, the infundibular retraction is much difficult in case of acute cholecystitis. So, what I did, I just give I push on the gallbladder. So, I expose the anterior callets, and I am not able to make a peritoneal incision on posteriorly because the exposure is not good. Two things, I have to decompress the gallbladder, and so that I can able to see the posteriorly. This case is no need, I am not decompressing it because usually when the traction of gallbladder is not possible, then we go for a decompression of gallbladder initially. Otherwise, we can manage with some other maneuver and then we can able to proceed. So, now I am just retracting, I am trying to see the posterior callets. So, it is not fully exposed, the posterior callet is not fully exposed. A lot of vascularity you will expect because a very large node is there, and then that is a lymph node, a lot of vascularity we will expect because of this edematous and congested thing. So, I am trying to separate the peritoneum, and a lot of small vessels on the cystic duct is coming from the cystic artery. It is a multiple artery of callets is there. So, I want to ligate the cystic artery first before going for a cystic duct, because the cystic duct is covered with multiple small arteries, that is called artery of callets. That is a small arteries coming out from the cystic artery to the cystic duct. So, I am trying to mobilize the node. I can't hold the node. Once you hold means it start bleed. If you have access is there is no need to mobilize and then excise the node, and we can leave the node on the patient side. Only thing we have to exposure is there, we can coagulate, we can clip the cystic artery and then divide without taking the node. That is an inflammatory infection, so it will be settled. So, now I am using, you can use a bipolar here or this harmonic, it will seal and cut, so that smaller vessels will be taken care of this harmonic scalpel. And I am using suction nozzle and harmonic scalpel. Alternatively, once the exposure is good, bleeding is not there, then I use a harmonic scalpel to divide the tissue, and if it is a vision is not good, then I use a suction to clear that area. So node is getting a little bit damaged, but this no problem. Anyway, I am going to remove this node. So now you can appreciate the cystic artery is coming in the view, because this a big node is on the cystic artery. So the vision is very much difficult. So now you can see the calyx, anterior calyx is seeing, two tubular structures is seeing nicely. That is the cystic duct. I am trying to coagulate the artery. So now I am dissecting the artery. That is the cystic artery is going to the gallbladder. So there is no doubt. So I can dissect the artery, and then I can able to apply a clip. So meanwhile, I trying to mobilize the, I am trying to do the posterior peritoneal incision, and I want to see the critical view of safety. So the posterior peritoneum, you can see how much the peritoneum got stretched, and lot of small vessels are there. So anyway, it is clear and posteriorly, and there is no other tubular structure seen there. So now I am coming on again anterior side, and then I am trying to dissect the artery, cystic artery and cystic duct. So that is the cystic artery. Tissue edema is there. So you can see when I apply coagulation, it is a lot of fumes, and more coagulation is happening because of the wall edema. So I am applying clip to the cystic. I convert my epigastric port to 10 mm now. I am applying clip to the cystic artery, and then one clip, and then I am dividing with the harmonic scalpel. You can ask now why you are not seeing the critical view. I just checked this posteriorly, and I am confident, and it is not possible in all cases. Some frozen calyx and some other conditions like empyema gallbladder, so we cannot able to see. But if you are posterior, you have to dissect, and then it's only the peritoneum got stretched, nothing else is there in posteriorly. Now you can appreciate here the stretched out peritoneum because of the gallbladder distension. There is no other structure is seen here. Since artery is divided, I could have some traction is less, so that I could able to mobilize the gallbladder medially, and then I am seeing able to see the posterior. Now you can see this, that is the critical view of safety you can see now. And these are all the branches of the cystic artery. I am just checking my instrument here, so it is able to see. So these vessels are again is going to the gallbladder. So I have to coagulate the vessel, and it must be from the posterior cystic artery. So the patient having a posterior cystic artery also. So that also I have to carefully dissect, and then I have to clip and divide it, because the bleeding, torrential bleeding happened because of the posterior cystic artery. So now I am doing this posterior calyx dissection, and because of the edematous tissue, and I could see, I can able to feel only one tubular structures here, that is the cystic duct. So nice window is dissected, and still multiple artery of calyx is there. So that is artery of calyx. We have to coagulate. It is surrounding that looks like a posterior cystic artery, posterior branch of cystic artery. So I am dividing all the small arteries coming from the coming to the cystic duct. So this is another anterior small artery is there. This is another artery. So here is another artery. You can see here I am just with the harmonic lower blade, I am skeletonizing the artery, and then I am dividing now. So these are all the small vessels covering the cystic duct. So it is cleared all around. So I am milking it out. This is very important. So I am milking it out now. So here I am using a Hemolog clip, that is a 13 mm clip. plastic clip, locking clip. So it is a 13 mm clip, and this is the titanium clip I am using here. It is a not a routine one, it is a large clip. Routinely I use medium large 9 mm, so this is a large 11 mm clip. Because of this thick edematous cystic duct, I am applying 11 mm clip. Again 11 mm clip, otherwise called sentinel clip on the infundibulocystic junction. So 3 clips applied. Now I am dividing the cystic duct. You can see after milking out, small stone is coming out, debris. So that's why the milking out is very important. I used to do multiple times before applying the clip to the cystic duct. Now you can see it is facing laterally, that means it is safe. And I am checking the posterior cystic artery. If it is a posterior branch of cystic artery is there, I have to coagulate or I have to clip. Normally I don't put a energy device on posterior cystic branch, and my preference is clipping because of the high pressure will be there on posterior cystic artery. So I don't use, even if I harmonic or ligature, I don't use, I put a clip and then I divide the artery. Even the gallbladder mesentery is edematous. Now you can see I am circumferentially mobilized, and then now I am clipping the post branch of cystic artery. Now you can see it is going to the gallbladder only. I am doing little bit dissection with the harmonic scalpel. Then my preference is hook, monopolar hook, to separate the gallbladder from the liver bed. So I am clear that area. So both the branch of cystic artery is clipped. So no worry about the bleeding. So now we can appreciate it is a edematous gallbladder mesentery. If you have a edematous tissue, you can reduce the coagulation setting to 25, so that otherwise tissue will take more current. I am doing on both sides alternatively, and you can see how much the gallbladder got distended. Previous 3 videos is before acute cholecystitis, lab chole was done. Gallbladder is very around at 7 centimeter or 8 centimeter length. This is more than 15 centimeter length, and the walls are edematous, thickened. Lot of fluid between the gallbladder wall and the surrounding structure. The peritoneum on the calyx is become thickened, so the traction, retraction, everything is become difficult. So this is one of the early acute cholecystitis, or otherwise called mild acute cholecystitis according to Tokyo guidelines, and it's a grade 1 acute cholecystitis. So to next video will be grade 2, and another one will be grade 3. So all the slowly difficult things I am going to uh, put the videos, and this is one of the early form of acute cholecystitis. Within 72 hours patient presented to us, and we are doing a total cholecystectomy in acute cholecystitis. So this is the gallbladder separation is completed. Now another task is there, retrieval of this gallbladder. So how much distended thick walled gallbladder, and usually it has a big stone at the infundibulum or infundibulocystic junction. So how to retrieve? The best thing is there is an infected one, so I am placing it into the endobag. Because of this habit, we are keeping even the regular gallbladder also, we are keeping it in a endobag and then we are taking it out. So now you can see this is the mucocele is becoming a pyocele now. It is not a clear mucocele, it's a pyocele is getting formed. A little late presentation, and you can appreciate the wall thickness. Normally it is only 1 mm, now you can see it is more than 5 mm wall thickness is there, and you can appreciate the very large stone. And I am dividing gallbladder into piecemeal. Usually I cut it into 3 to 4 piecemeal. Full length of gallbladder I cut into 3 to 4 pieces, then I can take it through the 10 millimeter epigastric port. You can see the very large stone and then small multiple stones also there, and it is within the endo bag. I am dividing the gallbladder, and on and off I clear all the infected fluid so that it is clean, the contamination is not there. So I'm taking at the 10 mm trocar, and I introduce the conventional long artery forceps. I take out the bag, mouth of the bag outside, and with the sponge holding forceps I'm taking the piecemeal of the gallbladder. I'm taking out the stone along with the gallbladder bag. So stone can be crushed and then we can take out the stone. We don't want, I don't enlarge the incision or the epigastric region. That 10 mm to 11 mm incision is enough. We can take any size of a gallbladder in piecemeal. So now I'm going to give a wash on the liver bed. Now you can see the entire liver bed is getting washed. There is no bleeding. So that is the excised lymph node that we have to remove it. It will come through the 10 millimeter trocar. So this is the video is completed now. Surgery is completed now. So this is the acute cholecystitis, total cholecystectomy. It is not a subtotal, it is a total cholecystectomy in acute grade 1 acute cholecystitis. So this is the final inspection on the porta. Everything is fine, is no need for drain. If everything is clean, no need for drain. Thank you.